Chris and Paul, and thank you to you. I realise you had a choice to make this afternoon, and I'm very pleased that you chose to come here. What I'm going to tell you is a very simple story, but I think a good illustration of how precision medicine has revitalised a clinical field, an important field of airways disease. 10% of patients have airways disease. And I coincidentally started with exactly the same quote as you used, Chris. Time to reform the taxonomy of chronic diseases. And this quote is particularly relevant to the situation in airways disease, where our classification system and the assumptions that we make when we classify disease have really not changed since William Osler's days 100 years ago. And it's a challenge that those assumptions and that classification system that has led to progress in our field. And progress was needed because outcomes, and here I show on the top hospital admissions with acute severe asthma, which is a good surrogate for deaths from asthma, have really not improved much since 2000. And certainly 2005, there's a worrying trend for this key outcome to deteriorate. And that's despite us throwing more money at the problem. So on the bottom, you can see that spending on asthma treatments, particularly inhaled steroid-containing treatments, has increased over roughly the same period by threefold. So we're throwing more money at the problem and seeing worse outcomes, and really that only because we're not targeting treatment effectively. We have a choice. We can do what the Finns do. I've just come back from Finland. They have extraordinarily good asthma outcomes, but they spend 3 times more than we do on asthma treatment. So we could do that, or we could focus on getting the treatment in the right people, precision medicine. And I'm going to suggest that second approach is the approach we should take. One other problem in respiratory disease is, like my football team, Leicester City, 3 years ago, we are bottom of the league of new drug discovery. And one particular problem in respiratory medicine is moving from phase 2 and phase 3 to a drug in the clinic has been very poor. And that's an utter disaster for the pharma industry, to invest a lot in the drug and then to lose it at late stage. And I will remind you that the pharma industry for airways disease and inhalers is overwhelmingly British, UK government. Now, I'm a golfer, and when things start going wrong in golf, you've got to look at the basics, your grip and your stance and your posture. So what are the basic concepts that we have in our heads for asthma? Well, if you look at guidelines and you look at textbooks, this is the sort of concept that you will see. Most of the clinical manifestations of asthma are driven by a particular form of airway inflammation, eosinophilic airway inflammation. You'll hear me call this type 2 inflammation because it involves type 2 cytokines that come from type 2 cells, Th2 cells. That drives an abnormality of airway function where the airways narrow too easily, which drives symptoms. And when they get particularly bad, the patient has an asthma attack or an exacerbation. So clearly the target has to be this driving pathology. And if we can drive the pathology, it would be perfectly reasonable to use symptoms as a surrogate of success. That was the mantra 10, 15 years ago. Now things changed because of a new technique to measure airway inflammation, developed by this guy who was a very modest Englishman in Canada who trained 70 professors of respiratory medicine in his career, quite a remarkable achievement. And his passion was measurement of airways disease. And when I was working with him, he developed a technique to measure airway inflammation by looking at the cells and mediators in sputum. Nothing, not rocket science. This is not DNA, this is not nanochip. This is good old-fashioned pathology. And this technique proved to be remarkably robust and applicable in patients even with severe airways disease. So when I got back to the UK, started measuring airway inflammation in all the patients I saw, and we started to see this sort of thing. So here are 2 patients with severe asthma. The patient on the left has disastrous airway function, as you can see from the diary card with peak flows all over the place, very high symptom scores, using loads of Ventolin, but no eosinophilic airway inflammation, in fact, the normal sputum. Whereas the patient on the right has very good airway function, but a sputum that is full of eosinophils. There seems to be a disconnect between pathology and clinical manifestations, which is very important. We were not able to relate the two characteristics of asthma at all. What did seem to relate to eosinophilic airway inflammation was the risk of attacks, and particularly serious asthma attacks. This guy, despite having a lovely normal diary card, had nearly died of asthma on 2 occasions. So the question became, what should be guiding anti-inflammatory treatment? You know, the presence of airway inflammation or symptoms which don't seem to relate in any way to airway inflammation. And that was a key question. This famous study, which has been cited 1,800 times now, it's the most cited paper in airways disease, asked a very simple question. Should you use markers of inflammation to guide anti-inflammatory treatment or symptoms? And the obvious winner was inflammation-guided management. And the big benefit of inflammation-guided management was a reduced risk of asthma attacks. What was interesting was that 40 to 50% of people with severe asthma in this study never had eosinophilic airway inflammation. So the model needed to change. The grip, stance and posture needed to change if we were going to hit the ball straight. This was a better model. We should view airway inflammation and abnormal airway function as relatively independent features of airways disease, which relate to key outcomes in different ways. So abnormal airway function relates more to symptoms, and abnormal airway inflammation more to the risk of exacerbation. And this model predicts that if you were able to reduce this, the main impact would be to reduce exacerbations. You would not have a big signal on symptoms and airway function. And at exactly the same time as we had this eureka moment, this study was published. Now, Mepolizumab was Glaxo's great hope. This was a monoclonal antibody that specifically blocked IL-5, the main cytokine involved in the development and the recruitment of eosinophils to the airway. This drug was highly effective at reducing eosinophilic airway inflammation. You can see the sputum eosinophil count went down to very low levels for at least a month after 1 injection. But it had no effect on symptoms and no effect on lung function. And this drug was shelved. It was one of those failures that we talked about earlier after huge investment. Now, I would remind you that this model predicts that if you block eosinophilic airway inflammation, you're not going to have an effect on airway function and inflammation. So after some persuasion, we were able to do a single-center study looking at Mepolizumab treatment for a year in 60-odd patients who we knew had eosinophilic asthma because they had sputum eosinophilia, and we looked at the key outcome related to that pathology, the occurrence of asthma exacerbations, and Eureka, the drug worked beautifully with a halving of asthma attacks over the year of the study. And I'm pleased to say this finding was replicated exactly in a 600-patient phase 2B study and phase 3 study. And we now have this treatment. And I treated my first patient on the NHS this morning with this drug. Now that's the background, but it's been hard work to get this thinking out there into ordinary clinical practice, which is very much my focus at the moment. And I don't know why. I'm an inarticulate Welshman, that might be one reason. But traditional disease labels, the one problem with guidelines is that they reinforce this thinking. And it's very difficult to change. They become rules, not guidelines. And the thinking becomes deeply embedded. I don't think people accept that they can measure airway inflammation, and they may have a point because sputum is a difficult technique. It certainly couldn't be done in primary care. But I think the main reason that this thinking hasn't permeated into primary care is that industry have not seen an opportunity. It's a bit like turkeys voting for Christmas. Precision medicine is not something that maybe industry at first sight wants to support. But all of these features are changing as we speak. Firstly, we have very simple biomarkers of eosinophilic or type 2 inflammation. The two that are likely to make it in clinical practice are exhaled nitric oxide. When IL-13, one of these type 2 cytokines, hits the airway epithelium, it causes it to release nitric oxide, which you can measure in the breath. And it's a beautiful biomarker of IL-13 activity in the airway. Blood eosinophils are reduced to very low levels by anti-IL-5. So a high blood eosinophil count may reflect IL-5 activity, and it's been a fantastic biomarker of response to anti-IL-5. These are tests that everyone can do, very simply. And using these biomarkers, we now have 6 different biological drugs at step 3 or later, all of which are showing encouraging signs of efficacy. Interestingly, they have rather similar clinical benefits, with a big effect on exacerbations, a small effect on symptoms and lung function. But they have very different effects on biomarkers, which are exactly those we would predict. So anti-IL-13 wipes out pheno, anti-IL-5 wipes out the blood eosinophil count, just as you would predict. And the other principle is the more type 2 cytokines you inhibit, the better results you get. And watch out for Mepolizumab, which blocks IL-4 and IL-13. It has extraordinarily good beneficial effects on symptoms and lung function, as well as exacerbation. And it also cures your atopic dermatitis as well. It will be a big new development. Now, I'm going to finish, if I'm allowed, just another clinical application of this thinking. Now, inhaled steroids are widely used to treat COPD, this smoking-related disease where the airways become progressively narrow. The benefits of this treatment are small, the cost is large, and there are concerns about causing pneumonia. So there's good evidence that inhaled steroids cause pneumonia. And the risk is related to dose and duration of treatment. Glaxo, the behemoth of inhaled treatment, 70% of all treatments in the world are made by them. Their new inhaled steroid had a particular problem with causing pneumonia. The highest dose in their phase 3 study increased death rates from pneumonia, a big problem. Multi-millions of pounds have been invested in this drug. So they phoned me up and said, let's have a look at this eosinophil count. And when we broke down the data by blood eosinophil counts, which were measured prior to treatment, 2 things became immediately apparent. The higher the blood eosinophil count, the higher the risk of exacerbations of COPD if you didn't take an inhaled steroid. If you did, that eosinophil-associated risk was taken out completely. The second key thing is all the pneumonia occurs in this group. And the deaths occurred in that group. So if you give a drug to people that don't have the characteristic that treatment inhibits, only bad things will happen. It's not rocket science. So this drug is back on track. So our progress in airways disease has really required us to fundamentally look at basics: grip, stance, and posture. And then we've started to hit the ball straight. Biomarkers of eosinophilic airway inflammation are clearly absolutely key to the proper assessment of patients with airways disease and the identification of patients suitable for steroid and type 2 cytokine blockade treatment. And we need to move away from our Oslerian view. And it's so hard to see why we can't. It's frustrating, but we need to move to a new view where we regard these airways disease in a slightly more accurate way. And industry is now engaged because it's solving their problem. Thank you.